All right, we move now to spontaneous abortion. Probably about 15 to 20% of recognized pregnancies will spontaneously abort. Here's our case. A 40-year-old woman, gravida 3, para 1, AB1, so this is her third pregnancy. She's had one pregnancy that went beyond 20 weeks and one that was a spontaneous or induced abortion. She comes in at 9 weeks gestation complaining of vaginal bleeding. And this is very common, very common. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness, and breast tenderness is one of the presumptive evidences of pregnancy, but it's gone. I don't like this. Pregnancy test was positive, initially breast tenderness, that's gone, and now she's bleeding. Now she has not passed any tissue at this point. Let's see how we're going to assess this. Here is a chart that we're going to look at to explore the possible managements of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy? Is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy? Could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical os is closed, ultrasound shows a viable pregnancy. We call this threatened abortion. Management, observation. If the pregnancy is going to be lost, there's probably nothing you can do to prevent it anyway, because the most common cause of first trimester loss is aneuploidy. If the cervix is closed and the ultrasound shows a non-viable pregnancy, no cardiac motion, an empty gestational sac, that is what we call a missed abortion. Actually, I prefer the term embryonic demise because it's probably already dead. This can be managed a variety of ways. A scheduled D&C, where you aspirate the urine contents, is a reasonable approach. Another would be just to await and let her see if she passes everything on her own. I've had patients who have elected to do that who said they were in labor for 2 days. And that they did not particularly appreciate. The other possibility is they may pass some of the tissue, but others remain. Then she has to have a D&C anyway. So I think a reasonable approach is a scheduled D&C. The other thing you could give is to give misoprostol, prostaglandin E1, to help contract the uterus. If we look at the cervical os and find it is open, and if ultrasound shows the gestational sac is intact, she hasn't passed anything yet, but once the cervix is open, it's just a matter of time. This is called an inevitable abortion. Management is going to be emergency D&C, because if she's bleeding, she can lose a lot of blood if you just wait even a few hours. If the cervix is open, some of the tissue has been passed, but the ultrasound shows some is still left inside. We call that an incomplete abortion. This also needs to be managed with an emergency D&C. If the cervix is open, ultrasound shows a clean uterine cavity, no placental tissue, no fetal tissue, all the products of conception are gone. That is completed abortion, and the management here is just observation. All right, let's look at some pictures. The most common cause of first trimester loss is aneuploidy. We already talked about that. The most common cause is Turner syndrome, trisomy 16. We mentioned that previously as well. 98% of Turner syndrome conceptions are spontaneously aborted. An uncommon cause of recurrent pregnancy loss is anticardial lipid antibody. This is where a woman develops antibodies against the fetal tissues or the placental tissues and results in recurrent pregnancy losses. We'll talk about that more under thrombophilias. The management for this is heparin, subcutaneous heparin. Let's look at ultrasound in evaluating first trimester bleeding. A common way of looking at the uterus historically was a transabdominal ultrasound. And this looks at the uterus and what's inside. Now you can appreciate that you're going to have to pass the ultrasound beam through the maternal abdominal wall. What if you have a big mama, weighs 300 pounds? That's going to be pretty hard to see. So an alternative is to use a vaginal probe. With a vaginal probe, you approach the uterine cavity through the vagina, and it doesn't matter whether she's 100 pounds or 300 pounds, you can see just as clearly. So if you're going to order an ultrasound because of first trimester bleeding, I would suggest do a transvaginal ultrasound rather than an abdominal ultrasound. This is a transvaginal ultrasound, and what we can see here is a small gestational sac. Now this is an early sac. You don't even know if there's an embryo in there. It's too small. You can see a nice decidual reaction, which is around the gestational sac. This is 4 weeks and 1 day. Here we see a nice, round, smooth, fluid-filled gestational sac. Too early yet to see any embryo. Here we see a nice, round, smooth gestational sac, and here we have the fetal pole right here. Now, I don't know where the head is. I don't know where the butt is, so we don't call this a crown rump length. We just call this a fetal pole. If you look carefully here, you can see a round yolk sac. The yolk sac should measure about 4 millimeters, and you should see cardiac motion. This would be a normal appearing ultrasound. Here's a nice ultrasound. You can see the crown rump length right here. Here's a yolk sac and nice, smooth, round, fluid-filled gestational sac. This is 6 weeks and 6 days. This is a gorgeous picture. 11 weeks, 4 days. No question about what's the crown, what's the rump. This is a wonderful confirmatory ultrasound. Now, what's wrong with this picture? We have a large gestational sac. It is 19 by 25 millimeters in size. It is round and smooth. It is fluid-filled, but there is nothing in it. It's empty. This is what has been called historically a missed abortion. Nothing is in there. Embryonic demise is probably a better term. What probably happened here was you had a trisomy 5, a monosomy 8, and you had a cessation of growth so early that you don't even see it. Now, sooner or later, there's going to be bleeding, there's going to be contractions, and the cervix will dilate, and now we then will begin a whole different diagnosis. But at this point, it is a missed abortion or embryonic demise. Look at this gestational sac. You can see it is fluid-filled, but it is not round and smooth. In fact, it is collapsing. And here we see a nub of tissue, probably just residual of a grossly abnormal karyotype. Here you can see an incomplete abortion. You can see that there is tissue within the uterine cavity. There is some of the tissue which is gone, some of it is left. This would be consistent with an incomplete abortion. So a threatened abortion, missed abortion, inevitable abortion, incomplete abortion, completed abortion, always remember, could it be an ectopic pregnancy or could it be a molar pregnancy? And we'll talk about those later. The sequence is probably initiated by aneuploidy. Aneuploidy leads to embryonic death. The placenta starts separating. We get vaginal bleeding. Vaginal bleeding leads to uterine contractions. Over time, uterine contractions will lead to cervical dilation. When you have adequate cervical dilation, you're going to have expulsion of the products of conception. If everything is out of the uterus, we call this a completed abortion. And here you can see the uterine cavity. You can see a clean endometrial stripe. There's nothing left in the uterus. Here you can see there is a little wider endometrial stripe, but clearly there is nothing left in the uterus. There's no need to take this patient for a D&C. My suspicion is that these diagnoses are probably the same pathological process, but it is just picking them up over time at different points. A threatened abortion can become a missed abortion. A missed abortion where the cervix is closed will become an inevitable abortion where the cervix dilates. Nothing has been passed yet. Over time, it will become an incomplete abortion, and we have tissue that has been passed, but some still remains in the uterus, which over time may become a completed abortion where everything has been expelled. So it's probably the same pathological process, but different diagnosis depending where you happen to pick it up over time. An important laboratory test that you should perform if you do a first trimester D&C is a type an RH, because if she is RH negative, then you want to be sure that you give RH immune globulin or RhoGAM to prevent isoimmunization. Let's just summarize what we've said. Our diagnoses are threatened abortion, cervix closed, viable pregnancy, observation. Missed abortion, cervix is closed, non-viable pregnancy, scheduled D&C. Inevitable abortion, cervix is open, gestational sac intact, nothing has been passed, but it's going to come. It's inevitable. Emergency D&C. Incomplete abortion, cervix is open, some tissue passed, some remains, management D&C, emergency. Or completed abortion, cervix is open, everything has been passed, management is observation. Now, let's say that she has a completed abortion, but you see the patient 12 hours after she's passed everything. What may very well have happened is the collagen fibers in the cervix have already started to come together, and the cervix may actually be closed. So open would be what you'd find if you find it immediately after the tissue has been expelled, but if you wait a while, it may very well close. And always remember, cervical vaginal lesion, ectopic pregnancy, or molar pregnancy. All right, and that's the end of spontaneous abortion.